Thanks everybody for attending the next Bytes of Innovation webinar. Bytes of Innovation is a webinar series where we do a deep dive into the future of medicine. And we do this together with experts such as researchers, physicians, investors, and lawyers. We do it every other Thursday. So we have one today, we'll have one in 2 weeks, and so on. The concept is 15 minutes of presentation by the expert, followed by 10 minutes of Q&A, which is moderated by Aline, who is the medical director at SecMed, and by me. So all participants, make sure to put your questions in the chat so that we can discuss them later at the Q&A. So today I'm proud to announce that we have Imon Banerjee among us. Imon is a scientist with a background in artificial intelligence and data mining. She holds a master's degree in information technology, a PhD in computer science, and she completed a postdoc in bioinformatics at Stanford. After this postdoc, she was promoted to instructor, and then she moved to Emory as an assistant professor, and currently she's an associate professor and lead AI scientist at Mayo Clinic in Arizona. Her research is on medical image analysis, natural language processing, deep learning, and 3D data analysis. And today, Imon will talk about her latest NLP solutions for curating large cancer databases. Imon, the floor is yours.
Thank you for the introduction, Martin. Let me first share the screen.
Yeah, of course.
Okay, so Martin already gave the introduction for me, so I'm not going to spend a lot of time like introducing myself. So I will just directly jump into the topic. I just want to make sure that I give the credit to everyone. So this is not only my work. So this is the work that I carried over from Stanford, Emory, Mayo Clinic. So just to start with that, actually, that cancer patients has a very complex representation. So you can imagine that a cancer patient goes through multiple types of specialty, heterogeneous modalities, as well as different types of historical data, starting from radiology images, reports, pathology images, reports, all the other electronics healthcare record data, starting from labs, lab tests, medications, records, and everything. So not only the multiple modality or multiple specialty, the cancer patient data is also divided into temporal timeline. So you can imagine that like suggesting a kind of treatment or suggesting a kind of treatment plan for the cancer patient doesn't really depends on only one single snapshot of a radiology imaging or a pathology imaging. You have to exactly look back all the history of the cancer patient just to understand what kind of treatment is suitable for them. So it's also needs this kind of temporal knowledge. So imagine that when an oncologist sees a cancer patient, he doesn't have to look at one single snapshot of the patient. He has to digest all this data that the cancer patient has. And it's very difficult for a human expert to digest all the data in a very short period of time that they have for every patient. So basically, when we try to model in a computer science language a cancer patient, you can see that there is 3-dimensionality of complexity. So you have the multi-speciality, you have the multimodality, as well as you have the temporal timeline. So let's just discuss a little bit about what I mean by multimodality or multi-speciality. Multimodality refers to the way in which something happened or experienced, right? So imagine that in our big data worlds, if we just consider the patients, we have data coming from medical claims, we have data coming from hospital EHR, provider surveys, like genomics data, patient registry, and everything else. Then the research problem is characterized as multimodal when you include like multiple of such modality, right? And dealing with the number of specialty like surgery, oncology, dermatology already brings you to this multimodal world, right? And not only that, actually, so you can imagine like starting from patient caregiver to the cardiologist, palliative care, like cancer, primary care. So cancer patients actually have the data for all these single specialty, right? So for artificial intelligence to make any progress of understanding the world around the cancer patient, it needs to be able to interpret all this multimodal data as well as this multi-speciality data. And it's not really an easy task. So if we go back and start looking at what kind of effort has already been done in that area, you will see that the cancer patient specifically needs this kind of like data linkage and data integration, because we see actually that the cancer patient outcome and the cancer, like which group of people are likely to get some specific cancer, depends a lot of like genetic heritage or any other like behavioral factor, like environmental factor, every other things, right? So the CDC National Program of Cancer Registry, NPCR, works to measure the progress in preventing, treating cancer, which is a leading cause of death currently in United States. And Cancer Registry is an information system designed to collect and store and manage of all this personal cancer data, right? So registry plays a critical role in cancer surveillance. And SEER is one of such registry, which is actually the full name of SEER is Surveillance Epidemiology and End Results Program. It's a main program that is actually led by National Cancer Institute to support this kind of cancer data curation, and this is not really like an easy task, again, as I was mentioning you before, because the CR mostly is kind of like manual data curation, which needs a huge effort and huge monetary investment, right? But if you look back, the CR began collecting this cancer data in United States in 1973, and currently CR is spread over like 9 registries, including California, Louisiana, Utah, New York, and funds, and CR also funds sometimes like combined program for the National Program for Cancer Registry with funding from these states. So as you can see that these dark blue regions are already have a CR registry, but all this middle region doesn't really have CR registries, because the fact that it's a lot of like huge investment, because it's mostly like manual cancer data curation. So if you go back and look the current CR process, how they are collecting this cancer data, you will see that there is a hospital registrar, and he or she actually is looking at the hospital database, structured data, clinic notes, radiology, pathology reports, and does the manual curation. And then as I was like dividing into two parts, so this part is actually only within the hospital system, and this part is the CR. So hospital system cannot share the full patient information with the cancer registry. They only share only a very selected information with the cancer registry, starting from structured data and few snippets of radiology and pathology report for the curation. That's why, since again in the cancer register side, actually we have a cancer tumor register, they also look back on this data curated by the hospital register to do a kind of like another case identification and verification before it goes into the CR registry. So it's a two-step process of the cancer data curation. So you can imagine that a lot of manual effort has been put on this data curation, but still the data that we are currently curating is only the staging, grading, and the first line of treatment for cancer patient, and cancer recurrence will only within the first year, which is a very limited knowledge, because most of the cancer actually recurred after the first year, right? So as I was like focusing on like few areas where the AI or this kind of like automatic data curation can make a huge impact. So the first thing that we can actually, it's very resource intensive process, this hospital registration. Probably we can do something to automate that part. And then there is also very limited data is shared with the tumor register. And we can also sometimes automate that part by selecting a portion of the data which doesn't have a lot of like patient identifiable information. Then also the tumor register who actually again go back and manually check all this data. It also is a resource intensive process, and we can also curate it automatically. So our proposal is actually to do a kind of automated curation, so that we actually completely replace the hospital register side. We do it a local AI execution. So where the can imagine that in an ideal scenario that you have an AI model, you just share with your hospital register, and the AI model automatically look back at the data without sharing any data with the tumor register, and curate the data and share only the curated data, including the date and the text snippets, where which has a more importance in extracting those data with the tumor register, right? And then we have also an NLP tool set at the top of the tumor register. They can also help the tumor register actually to automatically check those data and identify the flaw in the data for the curation. So it's like semi-automated process that we are proposing now. So how it helps is it helps in fast and automated curation, as well as not only this kind of like very few limited item in the cancer registry, but we can curate more and more sophisticated data, starting from like patient center outcome, like if the patient is feeling depressed, if the patient has like other behavioral change or something like that, including cancer recurrence. And cancer recurrence doesn't have to be 1 year. If we have access to the full medical database, we can curate the cancer recurrence for the all the year data that we have. Then also the treatment, we can also curate the treatment very efficiently. So if you look at the current workflow actually, so you can see that all the clinician, radiologists, clinicians, pathologists, they look at patient data, and they also generate a kind of free text reports, and these free text reports are basically used in cancer registry or by cancer register to actually look and do this kind of like automated curation. But because very rarely actually they go back and look at the images or the actual data values, mostly they're looking at the free text reports. But this free text report can also be processed, integrate and processed by the natural language processing automatically. But the main challenge is that these free text reports are really unstructured and cannot be interpreted by the machine due to the ambiguity and subtlety of the natural language. And every different provider has their own writing style, own template, and it's very difficult to boil down to a generalizable way in a way that the NLP model can curate it. So as we all know that since we are here, we are all interested in AI, and we know that AI model development depends a lot of the data training data curation, right? And training data curation is mostly like still a manual process. So you collect the data, you review the data, you recruit the reader, and finally you do the annotation. And it doesn't have to be in one shot because it's always like repetitive, right? Because then after the annotation, you sometimes feel like the data is not ready, so you have to go back and recollect the data and everything else. So it's like an iterative process, right? So it's laborious, expensive, and everything else. So our whole goal is how to somehow semi-automate also the data curation process for developing other machine learning algorithm, right? So we are not really only, our goal is not to help the cancer registry, but also do this kind of data curation automatically. So as you can see that before jumping into the method, I just want to show that if we have that kind of method, this is not only useful for cancer registry, but this kind of like automated data curation has effect on all radiology domains, starting for CT, MR, mammogram. So I'm just giving you an example of these domains because we develop method on these domains, but there are also like many other domains that can be generalizable. Then also there are clinical application, not only with imaging, linked with imaging, but you can have clinical implication for the cancer recurrence, patient-centered outcome, survival analysis, and many other things. So let's start with the radiology, because as we know that starting from 2014, the radiology is going more towards like structured templating. So you have for LIDARs for liver cancer, you have BT-RADs for brain tumor, you have TIRADs for thyroid cancer, you have BIDARs for mammogram. Then one, we need free text report because we already get scores from the radiology reports, right? But most of the hospital, they have like 50-50 distribution, who is using the structured template, who is not using the structured template. So the structured template is not yet widely popularized. And then if we go back, and we will see that only from 2014 onwards, the people are using structured reporting, but there is all the other data which is not structured at all. So we have to use some kind of technique that actually we use this kind of structured reporting as our training data set. And then after the training, we should be able to propagate also the structured code to the reports that were not created within the structured template. So basically, we have to find a way to annotate the full radiology or full pathology repositories without the structured templating. So this is the whole idea. But it seems kind of straightforward, because if we have annotation with the structured template, we can easily create a function around the free text, which can create an embedding, just a vector representation of the text. And then we can pass through the model and see that if it can predict the unstructured coding also from the reports, right? But then the question is like, what is the best representation for the documents? And what kind of numerical embedding would be best suited for this kind of task? But if we look at the structured report, we see that currently, this is an example of the hepatocellular carcinoma, which is the liver cancer. We see that the structured reports are already is like very structured within the sections, and also we have a score mentioned in the impression. But if we go separate liver finding and separate standard scoring system. But if we go to the unstructured report, we'll see that it's kind of like everything is mixed up and no trivial way to extract the liver finding, and there is no standard scoring for the liver lesion. So how we can train a model with the structured report and transfer it to the unstructured reporting, right? So, like there are a lot of other embedding techniques like doc2vec, like transformer-based embedding technique, but we actually took the doc2vec and we just projected the embedded space of structure unstructured, and we see that it's kind of like already separated because the model cannot mix the structure unstructured because of their like language formation, writing style. So it's very difficult to train a model from the structure report and convert it into the unstructured scoring system. So our methodology is that we don't only want to depend solely on this kind of deep learning based embedding method blindly. So we are developing a technique where we are incorporating the domain knowledge, natural language processing, deep learning, and semantic reasoning together in a combined way, actually, to manage this kind of like challenges with the templating, defined use of language, and everything else. So this is an example where we trained a model with the structured reporting, but we actually projected it back to the unstructured space, and we can clearly see that the high risk report are already clustered in one side of the space. We also did a kind of multi-institutional transformation. So we have trained the model using the Stanford data, but we tested the model on the Duke data, and we can clearly see that we can preserve the trend of the positive and negative reports. Then we also did a kind of transfer learning where we trained the model on the ultrasound space, and then we transfer the model on the MR space, and we can clearly see that the model still can merge these two language space very nicely, as well as it can learn the synonyms that learn from the ultrasound versus MR. For example, like bright is a very common word usually used in ultrasound, but isointense, hyperintense, they are used in MR space. So it can actually understand the synonymity between ultrasound and MR space. Given this kind of like interesting way to model the free text data, so now we are applying that to do the scoring. So this is a interesting example actually where we trained the model only on the 2017 data. Then we propagated the model to all the liver cancer patients, so we can actually infer their score starting from 2017. For example, this patient has the data from 2017 up to 2018, and we can propagate the score, and we can clearly see that the patient didn't have all the benign cancer till the 2016. Suddenly it went to malignancy, and at the same time also we found a cancer registry. Actually, they have a ACC classification of that particular patient. The performance of the model was very high. And then we also started doing like different analysis, how we can use this model more efficiently. We can clearly see that the model can also analyze the 10 years ultrasound screening data and identify why the ultrasound misses some cases. We also did the model training only on Stanford. We validated on UCSF, and we can clearly see that the model performance is quite the same between Stanford and UCSF. We also validated the case with California Cancer Registry, algorithm predicted versus radiology predicted between Stanford and UCSF. And we can again see that the model performance is quite stable between these two institutions, as well as between algorithm predicted and radiology predicted cases. We also tested this model on the thyroid malignancy, and we can again train the model on Emory. We validated on Stanford. We see that the model performance is quite stable. The similar technique we also applied for pathology report curation. So this is a web interface that we developed. So you can directly upload the full pathology reports, even in a batch, and the model automatically computes the higher order prediction as well as the label prediction. Also highlight actually the region where which words or which sentence are more important for predicting the this kind of higher order prediction. So which is kind of interesting, and soon this will be released as an open source system. Then we also start combining pathology, radiology, and progress note all together for recurrence data curation. So we divided the patient timeline into different quarters, and we combined the pathology, radiology, and progress note to predict that if the patient has recurrence within that particular quarter. And we trained on this huge number of reports, and we tested also on the 34,000 reports. And we see that our model actually performs very well. So our model is the neural recurrence model. It performed very well for definite recurrence and outperformed the basic rule-based and extended rule-based system. So once this model actually identified recurrence, we can again slice and dice the data of the whole tumor database in multiple ways, based on grades, based on tumor receptor. So once we have the recurrence label curated, so it's much easier to do this kind of like analysis. And we also wanted to understand why the rule-based model fails, because we can clearly see that this is a case where the rule-based model fails, where the doctor says that there is a tiny metastatic focus, difficult to exclude. So it's a very difficult sentence for the NLP to understand, because it says that there is a tiny metastatic focus, and the rule-based predicted it as definite recurrence, but actually it's not recurrence because it's not confirmed. It says difficult to exclude, right? But the neural recurrence model can identify those kind of cases. For example, it says like osseous lesions seen in the current study worrisome for metastatic. So it's not yet confirmed metastatic, but the model correctly highlighted worrisome as like word for no recurrence, which is kind of interesting. It can understand this kind of vagueness. But now we can also formulate a kind of independent patient timeline for every patient, and we can populate their recurrence data. So for example, this patient transferred to the recurrence in 2016, and we can clearly see that the text snippet says malignant neoplasm metastatic to brain. but we train the model again on the breast cancer recurrence, and we transfer the model to liver cancer recurrence. We can clearly see that the performance of the breast and liver still stays quite the same, which is very interesting because the primary site completely changed and the language page also changed, but still it can keep the same performance. We compare with the ICD code, and we can also see that the model performance compared to the NLP model performance compared to the ICD codes, NLP model actually able to include many more patients compared to the ICD. And California Cancer Registry, we can clearly see that it can also include all the patients in California Cancer Registry, but 90 patients was excluded because this 90 patients left Stanford and started doing their healthcare somewhere else. So we didn't have their clinical note. Because of that, actually, the model could not predict it. And then another interesting thing we found for this model is that the model is mainly trained for the distance recurrence, but it can also identify local recurrence. So you can clearly see that when we plotted the probability as a box plot, the mean probability for the local recurrence cases was 0.42, while the distance recurrence was 0.79. For liver cancer, we didn't typically find that because even there was like a lot of overlap, because liver cancer has some transplant cases where the model fails to identify the local recurrence, but still we can see that there is also a difference in the mean probability. We also developed the model for identifying the site of recurrence. So we can clearly see that the model can identify the site of recurrence with very high sensitivity and specificity for breast and also for liver. Then, since we have this kind of huge data set curated, so as a computer scientist, our next approach was how to use that data set, right? So we actually developed like a recurrence prediction model, so which can predict the recurrence 1 year in advance given all the visits, right? So patients is getting like radiology exam, surgery, oncology visit. We take all their data and start predicting recurrence 1 year in advance. But for the next patient, we found out that the visits type change, right? So if we look at the temporal timeline, it has a different visit compared to the first patient. So we also handle this kind of like different types of visit data. And finally, when we predict the recurrence, we see that only with manual annotation, we got 0.84, but manual annotation plus NLP generated annotation, we can boost the performance up to 0.94. So which is kind of interesting that this kind of weekly supervised data also help us to boost the performance of the prediction. Then actually, we also develop a graphical user interface where the doctors can click on each prediction notes and the model will automatically extract what type of note is that and what is the summary of the notes to make this kind of prediction probability. So it's kind of this study we did for metastatic cancer patient, and we are predicting the survival of metastatic cancer patients. So as you can see that the model is predicting the metastatic patients will survive up to this point, then the probabilities start dropping, and the ground truth actually follows closely with the predicted line, which is the green versus blue. And because the patient was doing like really bad, and it has urgent period of hospitalization, poor intake, nausea, pain, vomiting, then metastatic to pulmonary nodes and everything. But there are some cases where the model didn't work that well. For example, like these cases, like model predicted the patient is not gonna survive because the probability was very low, but then the probability suddenly went up and it find a progress not doing well without complaint. But at least the model can shows you the reason, because the model had only one time point before, and then the patient has an urgent period of hospitalization. So the model didn't have enough time point before to look at understand the history. Because of that, probably the prediction didn't work here, but at least the summarization give you a kind of way to dig the model more into deep. So our model achieved actually 0.89 AUC, and the doctor's prediction for this is 0.7. So we already overperformed the oncologist standard performance. But then there is another data component is missing, that how the patient is doing in the patient's own language. So usually currently the doctors is collecting the data based on survey. So we also extracted the data from clinic note, and we clearly see that the clinic note versus survey, we see the similar trend after the prostate cancer surgery, but we see that there was like some data is missing, because in clinic notes, actually, they don't have the regular recording of the patient-centered outcome. So we need to find a way how to fill that missing data gap, right? So now we are started looking at social media, and we are following the patients in the social media to extract the data from their Twitter feed and then combine with their clinical notes to fill those gap in the missing data. So this is our current project that we are doing. I'm happy to take any question. Thank you.
Thank you very much, Imon. This was a great, very, very interesting presentation. I think we should collaborate with you, because there's a lot of overlap actually that SegMed with what SegMed is doing. I think we should talk after this this webinar. I see there are quite some questions in the chat box. The first one is from Michelle. She has a question about SEER, the SEER that you talked about, whether patients can elect to have more than just structured data shared with it. So if they want to give more than just the structured data.
Yeah, so this is the problem of the generic healthcare data curation, that nobody actually like involve patient in this process. That is a big gap. And for example, like when we submitted, I will tell you the story, when we submitted the grant to NIH for the Twitter information, every reviewer said that no, the patient will never gonna allow you to integrate this Twitter data. But then we did a survey from the patients, and every patient was willing to share their Twitter data. We didn't tell them anything, but everyone is willing to share. That means that the patients want to participate in this kind of process, but the problem is that now we have this kind of mindset that we don't want to include the patient. And then the problem is that the patient moving from one state to another state, we should allow the patient to take their data with them, but very few healthcare organization is currently allowing that. So this is another big challenge that we have to deal with, that patients should have control on their data.
Yeah, I completely agree. Another question from Kaden: have you looked into making any industry partnerships to extract some of the data, for example, redox?
We don't, we are open for industrial collaboration, but up to now we did some collaboration with Philips and GE, but we didn't do the collaboration with other industries. Yeah, that's our bad.
Yeah. Let's see, Jack asks, how important is the last discussion part of the report? Okay, it's for machines to understand. So I think she talks about the impression part of the radiology report. How is that like the most essential part of the report, or is it there more valuable information in the rest of the report?
This is very interesting question, actually. So my NLP experience, I can tell you that we also did this study where we tally the impression with the radiology finding. And we found, and you will not believe it, we found that even both of the sections reported by the same radiologist, they sometimes forgot to mention some findings in the impression. So if you only parse the impression section, there is no guarantee that you can capture all the diagnosis that was mentioned in the finding. I know that it sounds stupid, but it happens. It happens because it's like human who is curating that data or writing or documenting that data, and this kind of mistake happens. So I think if you are really interested in the radiology report parsing, not only impression, but you also have to look for findings.
Mm-hmm. But isn't it that the impression will always have the most important, the essential,
they sometimes miss the findings. Those are important actually, because it's again depends on how you define importance, right? Mm-hmm. Because sometimes the importance depends on what kind of task you are targeting, right? But the radiologists are more interested in why this test was ordered, right? And they try to define the impression based on why the test was ordered. But probably you are going to use the data for something else, right? In that case, actually, you'll see that sometimes the information that you are searching is not there. It's actually in the findings.
Yeah, got it. You'll probably have more detailed information there anyway, so that's also adding value.
For Martin, probably you know that we are more interested in the lesion measurements, right?
Exactly.
And most of the time, the lesion measurements are missing in the impression.
Yeah, of course. Yeah. Okay, another question from Jack. Typically, how many reports will you use to train your models? To use your transfer learning? Yeah.
So transfer learning, actually, we don't need that many reports. For example, the MR versus ultrasound that I was showing you before, the ultrasound model was trained with like 100K ultrasound screening exams. But when we did the transfer learning with MR, we had only 12,000 or 15,000 MR reports, and that was okay for doing the transfer learning.
Got it. Yeah. Question from Kaylin. Assuming that most of the data is coming from academic institutions, the model performance on any non-academic institution types, such as outpatient clinics. Yeah.
So it's not only academic institution, because we, for example, the breast cancer data that I was showing you before, the breast cancer study also include PAMF, which is Palo Alto Medical Foundation. And we show that the model generalized well also on the PAMF data. We also did collaboration with VA, and for VA also the model was able to generalize very well. And Mayo also has some outpatient clinics, so we also get the data from them. But I agree that like the heavy part of this kind of study centered on the academic institutions.
Got it. Yeah. Jack is very excited about your research because he asked a lot of questions. The next question from him is your research open source?
Yeah, more or less. Like, so the main problem is that you guys probably know that de-identifying text data is kind of impossible, and no one is willing to go through this million of clinic notes to de-identify them. And so most of the academic institutions has a very strong like hold on the free text data. They are even willing to share the images, but not the free text note. So we have to go through a lot of regulation process to like allow the free text not sharing, but the models are always open source.
Mm-hmm. That's nice. Yeah. Oh, wait, let me add. So next question, any chance we could get access to your models and tools? I guess we do, because if it's open source, it
Yes.
should be available.
Please feel free to reach me. If you cannot find it in GitHub, please feel free to reach me, and yeah, I will be willing to share the code.
Cool, very cool. Do you have any recommended papers for us to look into?
Oh, I think I put some like citations below my slides. Also, you can find my name in Google Scholar, and yeah, we can share the paper with you.
Perfect. Let's see, then we have a question from Satarupa. Can you please let us know about some open access data sets? What about ethical issues faced while getting the data?
Yeah, so as I was mentioning before that it's very difficult to share the data in open source, but if you are really interested in the free text open source data, there is Mimic, of course, and there's different version of Mimic. So these are mainly ICU nodes that you can look for, and those are open source and but de-identified. But other open source data is difficult. But Twitter, for example, there is no limitation, right? You can get a Twitter developer account and download the Twitter data. But for our case, actually, we have to go through a semi-clinical trial, like observational trial, because we are looking for Twitter data for a particular patients where we have access to the clinical data. So we are merging the clinical as well as Twitter data. So we need a explicit permission from the patients as well as a clinical trial permission to get their data. So that was a kind of difficult, but otherwise, if you are going with open source Twitter, it's very easy.
Mm-hmm. Yeah, and additionally, actually, if for the researchers that are interested in working with large amounts of data that's fully de-identified, you can always reach out to SecMed, because SecMed actually does have access to a very large data, not only medical imaging, but also just medical data in general. So that's could be interesting for any researcher in this space.
Oh, that's pretty interesting.
Yeah. So yeah, we'll talk after this, Imon. Thank you again for an excellent presentation with a good discussion afterwards, I think, and also thanks to all the attendants for being here. We will publish this presentation also on YouTube, so you can always look back if you want to look at specific references, or reach out to Imon because her email address is on the slides and things like that. So for now, I would like to say thank you, Imon, and
Thank you.
for our attendance, I hope to see you in 2 weeks with our next Bytes of Innovation webinar.
Thank you. Bye.
Thank you. Bye-bye.